But to really have confidence in the outcome, he's going to take some time and actually show you the mechanics, the inner workings of how these templates work. And I think with that, you're going to really see the power that's involved. So, Dr. Brandt, would you walk us through how that works?
It would be my pleasure, Dr. Hodge. Yeah, Dr. Hodge went through that explanation extremely well. It has been taken, like I mentioned in the beginning, a lot of years of trying to come up with some way of consistency, trying to make things as consistent as we can in terms of producing clin checks that come back with regards to taking into account experience levels, taking into account a number of different factors. So what I'm going to do is I'm going to actually take you through some clin checks, and I sort of hand-picked a spacing case, a crowding case, and a Class 2, because that's the majority of the types of cases that we're going to see. I did not include an open bite or a Class 3 in there, even though, as you can see, you're going to pretty well be able to identify those types of cases ahead of time and get an idea of how you're going to treat them just with the assessment gauges that we indicated for you. One of the things that we need to do is I just wanted to sort of set the ground rules a little bit and talk about generally how we want to view this. One of the things I do want to point out is that, as Dr. Hodge was mentioning, that initial examination is critical. That's the sort of the groundwork. That's our initial diagnostic information that we need to take. Photographs, as he mentioned, are critical in the whole process. Not only critical for gathering the right amount of information, but also being able to evaluate your cases throughout treatment. And, you know, the better those photographs, the better the information is going to get into the system, and most certainly the better your treatment outcomes are going to be. So when we look at sort of three basic areas, let's talk a little bit about how these templates or how we can actually correlate them with your initial data, your initial examination. What we're going to do is at your initial examination, you're going to go through and actually determine the degree of difficulty by checking off the green, yellow, and red circles. And what that's going to do is it's going to give you an idea of how to go in and fill out your prescription form. It's going to give you an idea of the difficulty of the case. And it doesn't mean that those cases that appear to be difficult by having a larger number of clinical problems, it may mean that you may just take a different approach. That the approach that you take may be the best approach for that patient. So as I go through these case examples, I think a lot of this is going to make sense. So there is a strong correlation between the sort of the difficulty of the problems, the degree of difficulty of the problems. As you can see, anything that's less than 5 is usually a fairly easy treatment approach. And when I say easy treatment approach, it's a matter of mostly delivering aligners, following the aligners, doing what you need to do in terms of the attachments and IPR. But you're really probably not going to have to get into any other techniques like buttons and elastics. When you get up into the 5 to 8 sort of tally or total, degree of difficulty, you're going to see that most likely you're going to need to do something in terms of possibly buttons and elastics. When you get greater than 8, it's not only going to tell you that you're going to need fairly significant in terms of auxiliary treatment, but it's also going to be just a bit of a red flag saying, do you want to try and reach a Class 1? And like I mentioned to you and Dr. Hodge mentioned to you, sometimes Class 1 for the patients trying to reach those goals are really, really very difficult. And if we do that, many times we're leading ourselves down a path that no matter what treatment technique you use may be difficult to achieve. Moderate and difficult cases most likely are going to require, as I said, case refinement and other things to finish them. But the initial examination at chairside is really your first line of defense of looking at cases and analyzing them in a certain way. So let's look at a spacing case to start off with. And as you can see, I'm going to really, because we're trying to teach you a method and a process, as you saw with Dr. Hodge, he went through it in great detail, went over what mild crowding was, went over what AP classification was, and went over it more than one time. So what I'm going to do is I'm going to lead you through. It's almost like going through every single step. Most of the time we talk to the slide, I'm going to actually almost read the slide to you so that we can follow through on it. So the first case I picked was a spacing case, and this is the initial stage. This is how the bite was set, and most certainly with your articulated marks on the teeth, that's how the bite can be set much more accurately. Before you take your photographs, the technicians can use that to help set the bite. So what we did is we actually classified this case, just like Dr. Hodge was showing you, with your perioprobe, with your articulating paper, with your mouth mirror, with your floss. You're going to go in there and you're going to analyze the patient in a systematic approach using that assessment tool. So let's go through this one, and I'm going to start in the upper left-hand corner here, where we look at it. And remember we mentioned about using the first bicuspid. First bicuspid is really our best guide. Over the 30-some years that I've practiced orthodontics, and even before that as a general practitioner, I found that the molar classification of 1, 2, and 3 really doesn't give me what I need in terms of being able to, determine the true classification of how it's going to affect the rest of the arch. We know that the first bicuspid is actually our main guide, and it needs to fit down into this embrasure. As you can see in this case right here, the first bicuspid is medial to the ideal position where it should be sitting in that embrasure. So that's a C2. That's a classification of, is it class 2? We don't really want to think of it in those terms, but it's a C2, and we talked about that being a moderate sort of type of classification. At least that's the first determinant that we're going to look at, the first part of the assessment, the first classification. So we look at that on the right-hand side, and then we go over the left-hand side, and you can see it's symmetric. In other words, it's almost exactly the same amount of class 2 or C2 as it is on the right-hand side. So that's going to be added up as a 2, and that's where the number 2 comes up over here. It's where the number 2 comes up over here, C2. We give it 2 points. So if it was C1, it would be 1 point. If it was C3, it'd be 3 points. Remember, the higher the tally, the more difficult the case can become, depending on your treatment goal. So C2 on this case. The next one we want to look at is we want to look at the midline, which is MI. And that would be MI1 because the midlines, the upper and lower midlines, are close enough. In other words, they may not be dead on, and how often are the midlines dead on? But it's within the 1 to 2 millimeter range. The next thing we want to look at is overbite. We look at the overbite here. The overbite is more than 4 millimeters or around 4 millimeters, so it's overbite of 2. Over here, for the midline, we added 1 point to it. Over here, we added 2 points to it. And as you start to tally this up, you can see how we're starting to reach a summation of sort of clinical conditions that are present in this patient. Next one we want to look at is overjet. And the overjet is mentioned from the incisal edge to the facial surface, done with your perioprobe. And the overjet here is overjet 2 because it's within the range of 3 to 4 millimeters. So it's not greater than that. It's not up in the 6 to 7 millimeter range, which tells us that it's not a real skeletal problem. It's mostly a dental problem. But it's not normal, 1 to 2 millimeter range. And the last thing we look at is we're going to actually look at the spacing that we have here. So when we look at the spacing, and over here, let me just first of all talk about the tally. So that would be 2 points. We'd add that in there. Now what you got to do is look at the spacing upper and lower. And in this case right here, the spacing goes all the way back to the posterior. That's what makes the case a little bit more challenging. Having those spaces in the bicuspid area means if we do want to treat this case to ideal, it most certainly is going to require a fair amount of root movement, and that's really what we want to look at. So because there's spacing all the way back in the bicuspid area, we gave it a 3 on the upper, and because there's spacing all the way back in the bicuspid area, we gave it a 3 on the lower. Those two classifications, when you multiply up and add 6 more points to it, takes us into 13 points. And one of the things that I've learned is that, as I mentioned to you before, anything less than 5 points is usually a fairly easy case. The 5 to 7 range is moderate. Usually you can get the job done and get the case treated out nicely. But anything that's over 8 points, you have to start thinking about what's my best treatment approach. And that's when you go into your prescription form, you're going to decide whether you wanted what type of treatment approach you want to see. If you want a solid, ideal class 1, let me show you what that looks like, and let me show you sort of what that can mean in terms of overall treatment. So here we are, Class 1, final stage, ideal setup. In other words, a perfect setup, all the anterior, posterior corrections done, midlines are remained where they are, dead on. The overbite is ideal. The overjet is ideal. All the spaces are closed. What would that take? So the classification before, remember when we went through the classification before and it added up to be 13 points? Now, if this patient walked in the door, obviously they wouldn't need any treatment, but if they did and we did the same classification, you can see that the AP relationship is now a 1. It went from a 2 on the last, the initial setup, to the final setup, it's 1. So we classify that, we give it 1 point. Midlines are on, so that's 1 point. Overbite is on, so that's 1 point. And all of a sudden you can see right here, because there's no spacing, because there's no overjet, because there's no spacing on the upper arch, there are no points added to that. It's now a 3-point degree of difficulty. So we went from 13 points down to 3 points, and the difference between those is how much? 10 points. That difference is what's really important. When you have a difference that's greater than 8 points, it tells you that it's probably going to be a lot of challenging movements in order to go from the initial setup, or from the initial bite, the initial malocclusion, to an ideal setup. So let's see what it would look like if we decided, and this would be if you went back to, and let me just take you back one slide here, if you went back to this one and you looked at it and you said, I want perfect, and you checked off the red box or the red circle and indicated you want perfect, that's what the technician would send you. This would be the template the technician has for this type of spacing case set up. So because of what we had initially and wanting to go to ideal, it took us into a range, a difference that was much more than probably we want to treat. So let's just look at what it would be like if we didn't move those posterior teeth. Let's see what the difference would be in point levels. We would still have a nice anterior setup. We would still have a stable posterior occlusion that we started off with. All the anterior spaces would be closed, probably what the patient's chief concern is, and not making those root movements. We could also decide if we wanted to do anything in terms of, depending on the age of the patient, this is a teenager obviously with virgin teeth, but if it was an adult, we could go in there and we could even build those teeth up if we felt we wanted better stable occlusion. But that posterior occlusion is stable, and it's probably not going to change much with time. If it is going to change, it'll probably move in a more improved position without doing anything. So let's look at this case 1 final stage with the left posterior spaces, no AP correction. So we left the spaces in the back. We closed all the spaces in the front. So now what we have is a degree of difficulty of 1. And why? Because we went, excuse me, from 13 points on that original classification, and when we add up now, because we left the posterior and we didn't include that in the treatment, it now is only 11 points. So if we analyze this case, it now is at 11 points. If we subtract those two, the difference is 2 points, which is really insignificant in terms of treatment. And we know on Invisalign treatment cases, closing space is very, very predictable. And regardless of what you used, if you wanted an ideal treatment approach on this case, even if you weren't using Invisalign, you were using other orthodontic tools, it would still be a difficult case because they're difficult tooth movements for any type of appliance. So let's now look at a crowding case. And it's case number 2, initial stage. And most certainly when we start off with, and I'm going to go through this a little bit more quickly because I'm assuming now you're following things along pretty good. So C1 would give us 1 point because the first bicuspid fits right down in the embrasure, both the right and the left-hand sides. If we look at the midlines are on from the beginning, so that's 1 point. Overbite is pretty well ideal, so at least ideal for this patient. It's not an open bite. We do have overbite, so that again is 1 point. The overjet is 0, so there are no points added to it. And then if we look at the crowding, as mentioned before, where's the crowding confined to? Only the incisors. Only the incisors. Even though if you looked at the lower arch, you'd say, my goodness, and the patient would say, probably, you got to extract a tooth, right, doctor? Or you're looking at that thinking it's significantly crowded. that really is not. That is mild crowding because it's confined to the incisors. And through treatment with expansion, little bit of IPR, depending, no matter how you're going to treat it, it's going to be an easy treatment approach. So the Invisalign only treatment, and this will be if we decide that we want to go, and most certainly on this case we do want to set it up to ideal. Let's see what that's going to look like. So if we do set it up to ideal, as you can say, the initial was a 5-point, for the initial classification was 5 points. Now that we've treated and got rid of the crowding, it's now down to 3 points. The difference is 2 points, and you can see how easy this treatment is going to be. With a little bit of expansion that was done in this case, with a little bit of IPR, we were able to maintain the midlines. Of course, the class 1, the C1 was maintained from what we had initially, and the overjet was, we had contact initially, and that's where the patient was functioning, and that's what we maintained from the beginning. So you can see that most certainly in class 1 crowded cases, it's really important to look and see where the crowding is and to what degree, but most certainly crowding that's in the mild to moderate range that's confined to either the incisors only or includes the cuspids is really easy treatment. And even if it includes the bicuspids, because we can do all kinds of expansion, do all kinds of other treatment, in most of those cases can be treated very successfully with Invisalign. Now let's look at the last case here, and it's going to be a class 2 case. So it's the third case I picked, and these is ones when they walk into the office many times, the patient's really concerned about these anterior teeth. And it's the lateral incisors that are supporting the lip, but it's the teeth that they would just as soon not have in that position. They're usually happy with the central incisors. So the question is, as you know, on these cases, most of the time the posterior occlusion doesn't fit. And we do get lucky sometimes and have this anterior relationship with a class 1, and that's what we call a class 1 division 2 rather than a class 2 division 2 as this one is. So if we start adding up all the degrees of difficulty, you can see that we are class 2, which gives us 2 points right here, C2. Midlines are on, that's 1 point, C1. Overbite is 3. So in other words, we've got a very deep overbite. Part of that has to do with the upper central incisors being tipped in that position, but sometimes it's even how the bone develops, so it's important to know. Regardless, the other thing that we need to look at, too, is the overjet. What we usually do is pick the most prominent tooth, measure it, and on this one it's the right lateral incisor, and we measure that from the incisal edge back to the facial surface, and it's significant enough to actually add 3 points. It puts us in the 3 range, into the red zone. And so how many areas do we have in the red zone right here? So we've got 3 areas in the red zone with a class 2, which means that it's greater than 8 points in the degree of difficulty. If we want to put a classification to the 1, 2, and 3, we're starting to get, it can be difficult if we want to treat this case to ideal. And most certainly treatment time, auxiliary techniques, all kinds of different things need to be done in order to correct this posterior occlusion, because that's where most of the degree of difficulty is. Let's have a look and see what it would actually take, and you're going to be kind of surprised of what it would take to correct this to ideal. So if we go through the classification now, if the patient walked into the office in this type of relationship and said, I want this upper space closed, but the bite was in this position, you could see we're down to 3 points. Why? Because it's an ideal posterior occlusion. We've gone from class 2 to class 1. And the overbite is improved. The overjet is resolved. And so all of those things that gave us the classification 3 has been resolved, so now we're down to 3 points. What's the difference between the initial, which was 11, and the final, which is 3? It's greater than 8 points. So it's, those are one of the things that at least the initial examination, by adding all up and having the summation of those points, is going to guide you on how you want to treat the case. So if you decide you want ideal, it's going to be greater than 18 months, the degree of difficulty, because of all those different, all the red circles that would have been circled. You can see that it's confirmed in the diagnostic setup. And look what's interesting here. In order to get an ideal posterior occlusion, space had to be left distal to the lateral incisors. Something that most people don't realize is that the thickness of the teeth buccolingually also plays a role. So that's the beauty of having ClinCheck, and that's the innovation. As we talked about the pyramid, the basic principles of occlusion, experience, education, but it's nothing like having the technology to bring it back home and say, here's what the ClinCheck would finally look like. So for whatever reason, you decided, even though the numbers indicated it would be a difficult case, you wanted to see what it would take, most certainly you can ask the technician by checking off and circling that red circle indicating that you want an ideal setup, this is what you can expect back. And they would leave that space distal to the lateral incisors. Why? Because they're not going to do IPR in the lower arch in a Class 2 with a deep bite, and the technician is going to send it back. But then you have to worry about or deal with that space. So what would happen if you actually decided to check off the green circle and ask for a very conservative approach to the treatment? What would that all entail? Well, as you can see right here, if we didn't correct the posterior occlusion, and we took that and it was still Class 2, we would put a 2 in there. And if the midlines, which we're on in the beginning, that would be a 1. And then most certainly if we have an overbite, the overbite was improved from 3 to 2 just by aligning the anterior teeth, because that's what we did in this case. We did not correct the posterior. So now you have a 2 in there, so it goes from 3 to 2. And as you can see right here, the overjet still is significant, and that's a 3. So that was not resolved. Now, if you looked at it from the anterior view, other than having the large overjet, you would still have anterior alignment. You would still have a stable posterior occlusion, because that's what the patient walked in the door with. That's probably the most stable occlusion that the patient is ever going to have. And the crowding is resolved, so we've knocked that down, and it adds up to 8 points. The difference between the initial classification and the final setup classification is 8 points, which means 3 degree of difficulty 1. In other words, getting this type of ClinCheck or getting this type of treatment result is very, very predictable. But let's assume that the patient doesn't want to live with this overjet. Let's assume that we want to get rid of some of that overjet, but we don't want to look for an ideal posterior setup. So let's look at another treatment approach by doing IPR. Rather than taking out bicuspids on the upper, which would be too much space, how about if we did interproximal reduction from the first molar to first molar on the upper arch? How much can we actually reduce the overjet? Can we get it into a very functional, good position? Because of the amount of overbite, we know that the patient's, those teeth would rub and protrusive. So we know that that would be a much better functional occlusion. So let's see how much of a difference, let's see how predictable that would be. So if we go through the classification just like we did with the initial one, where we still maintain the posterior occlusion at C2 and give it 2 points, midline on 1 point, overbite about the same as the most conservative approach. We went from 3 to 2, and we left the overjet the way it is, so I still even included the overjet as a 3. That would still take it up to 7 points, but even with him giving, a 3 for the overjet, which I could probably have given it a 2, we're only 4-point difference. The 4-point difference between the initial and the final setup is less than 5, which means this is a very predictable approach as well. So what I'm going to do now is I'm going to turn it back over to Dr. Hodge. He's going to kind of close up. I think some of my closing remarks are that let's think back to what we said, and let's think back to some of that pyramid. Let's look at some of the basic concepts, or principles of orthodontics, and looking at occlusion, and going in and doing that initial examination, I think, is going to give you a much better idea of what type of treatment approach, what type of ClinCheck you're going to expect back. You can communicate much better with the patient. And then when you get your ClinCheck back, that's going to be sort of your final way of being able to, validate what you saw clinically, and then you can make the decision on how you want to go through the treatment approaches. Dr. Hodge?